First, I acknowledge the traditional custodians, the Gubbi people of the Sunshine Coast. To elders past, present and emerging, I acknowledge this always was and always will be Aboriginal land. Respect to all Aboriginal and Torres Strait Islander peoples. Hello, my name is Susie Scrimshaw. I disclose to you that I am an autistic woman. This presentation offers an adapted version of findings from my research undertaken in 2020, tailored to stakeholders of community and youth services. I produced an integrative literature review exploring existing evidence and perspectives around the relationship between adolescent autistic natal girls and significant gender variance. Findings serve to inform support programs within the community sector, as well as those involved with the diagnosis and treatment of neurodiverse adolescent girls concurrent with gender dysphoria, rapid onset gender dysphoria, those who are questioning their gender identity, and even those who may not identify or conform with the gender binary at all. Before moving on, I want to offer a few key definitions. The Diagnostic and Statistical Manual of Mental Disorders is now in its 5th edition, published in 2013. Known as the DSM-5, it is used by clinicians for diagnosing and categorizing gender dysphoria and autism, and offers labels of classification to the challenges we know collectively as mental health. Gender variance is defined as gender identity or gender expression that does not conform to traditional masculine and feminine gender norms. Gender dysphoria is the distress resulting from incongruence between assigned and experienced gender. Autism is characterized by difficulties with social communication alongside repetitive restricted behaviors, interests, or activities. A key distinction is that gender dysphoria and autism are in the DSM-5 and gender variance is not. First, some context. It was in the 1980s that the first few specialist child and adolescent gender services were established. Hormone-blocking treatment in the early stages of puberty was not available, and a social transition was rarely made before presenting to specialist services. The first such service to open in Australia was in Melbourne in 2003, with further clinics emerging in capital cities adjoined with paediatric hospitals. This is one example of Australia being roughly 20 years behind this Western trend. Moving forward with the recent research, following a systematic searching of academic databases, 4 major themes emerged within the collective included literature returned for my review, some with sub-themes. The first theme surfaced within a critical appraisal process where numerous articles reported using conflated language. To provide an example, an autism specialist team of Australian and Polish researchers advocate the need for the development of clinical measurements relating specifically to the female presentation of autism. In recognition, it is different to that of males. Yet their own datasets use the terms gender and sex interchangeably as if they mean the same thing, creating a risk of interpretation errors. This was a common theme throughout literature of autistic studies, and this table lists articles primarily about autism. A recent 2020 editorial by Dr. Strang and team in the journal Autism claims that sex and gender are often conflated in this work, with gender often viewed through a rigid binary lens and attached to biological sex. He and his team know this well, given Dr. Strang was the director of a gender and autism program in Washington, D.C. Research around gender dysphoria, however, conflates language differently. The same Dr. Strang with team in a 2018 paper provided no baseline natal sex data from which to sequence the gender identity path of the subjects in reporting findings from their study. Another example is of results being reported based on the preferred pronouns of the subjects, with another grouping both natal male and natal female together within datasets, including grouping non-binary and binary trans identifications together. Of concern are the recent dates of these publications and the consequence for practice in the community health sector. The second theme explores prevalence. In 2013, there were 30 new referrals to one United States pediatric gender service. This number has more than doubled with each subsequent year. This pattern is becoming more prevalent in reports from specialist clinicians in Western countries worldwide, including Australia. Correlating with the rapid increase is the rising number of gender clinics emerging in the Western world. Elevated rates of autistic traits within gender clinic subjects have become evident too. One study reports trans men, so baseline is natal women, to have more autistic traits than natal women controls, as measured by the autism spectrum quotient. This presented in cases where autism is not diagnosed. Frequency of non-binary identities is not well represented in prevalence data in results returned for this review, yet early signs of correlation can be observed. This 2008-2011 intake cohort in a Canadian gender service found adolescent cases exceeded child cases for the first time since it was established. This figure offers a vignette visual of the phenomenon being echoed around the globe. The shift in prevalence ratio from children to adolescents accompanies a shift in sex ratio within adolescent cohorts, from traditionally higher numbers of natal males to predominantly natal females. The few new representative samples of adolescents self-identifying as transgender or who adopt gender identity labels alternative to the binary indicate higher prevalence in natal females, yet some experts assert many would not meet formal diagnostic criteria for gender dysphoria. Concurrent autism and gender variance was first documented in Sweden in a single case study in 1997 in a natal female child of Pakistani origin. More recently, a systematic review by United Kingdom clinicians in 2016 found literature around the co-occurrence limited. A 2018 review of global literature conducted in Norway reported adolescents to be the least studied age cohort in the publications. Overall, autistic individuals present 7 to 13 times more frequently than non-autistics to gender-related services. There were various hypotheses, yet a systematic appraisal led by a Dutch team of researchers in 2016 found most to lack evidence. There are no concluding risk factors at present. A paper from the United Kingdom contributes differently. I adapted this graph to emphasize the linear line, and research since 2012 has reinforced this trend. Our target population is the centered dark column identifying as trans men. The comparative study found trans men had a higher median autistic quotient than typical females, typical males, and trans women. Yet they also had lower autistic quotient scores than autistic subjects without gender dysphoria. This means their range of autistic characteristics falls part way between typical autistic presentations and typical female controls. The third theme focuses on autism in females. A qualitative paper by feminist scholar from the United States published in 2012 defines gender as quite literally a performance for some autistic women. This concept is known as masking and emerged thematically in a systematic review conducted by Australian psychologists in 2016. Where social skills seen in typical peers are imitated by autistic females, thus masking features of autism. This is increasingly recognized as a core characteristic of the female phenotype. Masking behaviors are most prevalent in less severe autistic profiles and therefore considered a contributing factor to the comparatively low and late diagnosis rate of females. Research reveals the male to female sex ratio ranges from 2 to 1 to 4 to 1, but the true prevalence of autistic females is not known. The measurement deficit stems from females not fitting into a typical male-orientated clinical description of autism, so they often fail to reach diagnostic thresholds. Studies of autistic cohorts in relation to gender development are also lacking, and those that do exist frequently use deficit-based comparisons to typically developing controls, and often with male bias of reported data. A few points of interest noted in the collective research around this theme includes autistic females are not particularly feminine, and tomboyism is common. There is a preference for socializing with male peers, with some evidence linking this to male typical patterns of systemized thinking in autistic females. Special interest topics are a feature of the male phenotype that also exists in females, yet presents differently, often aligning with interests seen in typically developing female peers. Typical gender role characteristics display a non-conforming gender identity in autistic individuals. In a 2018 Australian study, 219 autistic female subjects were compared to controls. 33.3% of the autistic group did not identify with the gender pertaining to their natal sex. Of interest, 80% of the gender-variant autistic females identified with categories such as genderqueer and other, rather than the opposite binary sex. Likewise, a study in the UK found that 26.5% of 101 autistic natal female subjects disclosed non-binary identities. Lastly, a study by Dutch researchers in 2018 determined autistic natal female participants considerably more likely than controls to identify outside binary categories altogether. Studies of case files reported by gender specialists usually come with treatment suggestions and typically from a binary affirmation-based stance. This present clinical reality is substantial when synthesized with findings that autistic phenotypes of gender variants simply do not fit current standard clinical categories of typically presenting gender dysphoria. In the absence of a reliable evidence base, social and cultural factors are arguably more influential in driving change in gender-related healthcare. Further research is vital, especially around autistic females who are not akin to autistic males, nor are they like neurotypical gender dysphoric natal females. The extent to which this rapidly developing concept can be understood as a normal variation of gender expression, a social construct, or pathology is a matter of ongoing debate. Something outside the scope of this literature review that I learnt along the way is that explorative questioning by clinical researchers such as Dr. Lippman in the US and Dr. Zucker in Canada have in some cases cost them their jobs and/or professional reputations for developing hypotheses that are not synonymous with strict affirmation-based declarations. I will come back to the importance of exploration shortly. Psychopathology is the final theme. Sub-themes include adolescent vulnerability, rapid onset gender dysphoria, and desistance and detransition. 3 systematic reviews confirm a correlation between gender dysphoria, autism, and vulnerability. An Australian study published in 2020 found a heightened risk of autistic women being more vulnerable in having unwanted sexual experiences than that of both neurotypical females and autistic males. Low levels of self-esteem in autistic females increase vulnerability to various forms of physical and sexual abuse. In her 2018 study, Dr. Lisa Lippman coined the term rapid onset gender dysphoria in an attempt to give name to an emerging category of gender dysphoria, characterized differently to the more widely understood persistent gender dysphoria, which typically manifests from a very young age in predominantly natal boys. Parent reports from Lippman's study uncovered a pattern of whole friendship groups of natal females coming out as transgender together. United Kingdom researchers in a 2019 study claim that the trend correlates with greater availability of information in society and media. Lippman raises concerns of the effects of suggestion upon youth within social media sites. Prior to this, in a 2011 to 2013 cohort study of adolescent natal girls attending a gender clinic in Finland, uncovered that 83% were bullied for something unrelated to gender before the onset of gender dysphoria. The adolescents commonly felt socially and/or academically marginalized, had persistent experiences of bullying before the onset of gender dysphoria, they had low school attendance or low school engagement rates, experiences of social anxiety and depression, and they also held very high expectations that gender-related interventions would solve their problems in social, academic, and mental health domains. The clinical hypotheses raised by the Finnish research published in 2015 is that the enduring feeling of being an outsider among peers experienced by autistic children could play a role in their developing gender dysphoria in adolescence. The clinical experience of a Canadian team reporting in 2017 is that many gender dysphoric youth expressed lacking words to describe their feelings until they began searching the internet, saw the topic discussed on television, or received information during a health class at school. In 2016, Australian researchers reported that autistic individuals experience greater difficulties adapting to physical changes of puberty, thus increasing susceptibilities to psychological symptoms compared with non-autistic peers. Of interest, despite what we know about increased sensory sensitivities in autistic populations, no discussion of the adolescent female experience of the menstrual cycle was found in return literature, nor the effects traditional gender role expectations such as hairless legs and underarms. Further research for understanding this cohort is paramount to our understanding how to best support them. Numerous studies suggest that the majority of gender-diverse children, as many as 84%, revert to the gender congruent with the sex observed at birth when they reach puberty. These children are now known collectively in the literature as desisters. Those who continue on through adolescence and adulthood with a continuing transgender identity are known as persisters. A United States study in 2016 reports on the consistently high rates of desistance in transgender identity among children as they grow into adolescence as a typical experience of this cohort. Yet the rate of desistance in adolescents with rapid onset gender dysphoria is currently unknown. In 2019, a United Kingdom gender clinic reported 12 individuals with adolescent onset gender dysphoria actively requesting medical interventions to cease the desire for such within a 14-month period. Yet more research is clearly needed around adolescent onset cases. A growing concept is of individuals with often physically healthy bodies seeking medical interventions in an attempt to relieve the distress of gender dysphoria by having sex characteristics better match their gender identity. For native females, this may begin with puberty blockers or testosterone, and later surgical removal of the breasts. Presently, research reveals an overrepresentation of natal females desiring gender-related surgeries, with many believing chest surgery and testosterone essential. When observing persistent gender dysphoria over more than a decade, a medical pathway of gender affirmation is commonly regarded as compassionate and appropriate care. However, in the context of rapid onset gender dysphoria, Dr. Zucker in 2019 emphasized that any clinical guidelines are merely suggestions, and for a gender clinic to be fixed in their models of affirmation would be to ignore the rapidly evolving new discourse. Like all clinicians, gender specialists are obliged to continue their professional education and keep up to date with current knowledge. Of critical relevance, medical specialists commanding a cultural authority deriving only from the value of their subspecialized medical knowledge is a form of malpractice stressed by legislative specialists. Stakeholders supporting affirmation therapy must not claim ownership of the concept of identity development with entirety, but rather consider the developing intersectional literature to guide emergent legislative frameworks from which clinical guidelines stem. In relation to autistic populations and rapid onset gender dysphoria, acknowledging that data on desistance is exceptionally sparse is a substantial part of the medical equation. It has been suggested that some professionals and activists are reluctant to acknowledge the existence of desisters and detransitioners, possibly fearing they may delegitimize the experience of persisters. The soon-to-be-published 8th edition of the World Professional Association of Transgender Health Standards of Care will include a section on detransitioning for the first time. This confirms it is an increasingly witnessed phenomenon worldwide and an essential part of the conversation. It also highlights that there are no guidelines or recommendations that exist for those working with desisters or detransitioners. There is currently very little research and no clear guidance on how to work with this population. Conclusions regarding optimal diagnostic procedures, treatment protocol, and outcomes are currently lacking. Cautious approaches are thus recommended by various clinicians and researchers. Where cases of adolescent onset gender dysphoria emerge, exploratory psychosocial treatment without social transition and hormonal suppression is recommended by some. Treatment focusing on helping children become comfortable with their natal bodies is described in one 2014 study, yet this concept is not genuinely explored in collective literature returned. Homogenizing gender variance to a culturally narrow criteria stunts the potential notion of living in a more non-gendered way. Discussing gender identity through the limited lens of persistence or desistance of more typical clinical gender dysphoria offers little prospect for gender variance and diversity of identity to be explored with accurate entirety, and unproductively anchors the discourse in that of medical decisions and iatrogenic risk. In summary, it is evident autistic individuals do not form their identities the same way typically developing people do. By nature, autistic people are resistant to elements of social conditioning and are therefore non-conforming in many ways, of which this extends the development of gender roles and meaning-making. This also means they may not form LGBTQI+ identities in the same way neurotypical people do. Being natural nonconformists of the neurotypical binary undoubtedly leads to confusion for some, yet attempting to conform to the trans binary may not be the right fit either. If affirmation is rigid during an experimental or questioning stage of adolescent development, such well-meaning intentions can create a barrier to true exploration of the autistic identity. As adults, It is not only our role to hold the door open both ways for our collective youth, but ultimately support them through an ethical framework of holistic harm minimisation in finding their own way unhindered. I will now return to the issue of conflated language as urgent collaborative response is needed. Individuals facing decisions around their combined gender identity, sexual identity, and autistic identity first need a solid language base from which to communicate their self-concept, as do the many stakeholders of various roles and responsibilities who care for them. I designed this simple tool to offer a tangible baseline, as is needed for this work, whilst also respecting individuals' self-identifications. Recently, I asked a few local gender dysphoric autistic natal female youth how they feel about the term observed female at birth, or OFAB, rather than the term gaining traction in social media, assigned female at birth, or AFAB. To better reflect the experiences of caregivers around the birth of an infant, with respect for both family relationships and clinical roles of medical care providers, it is important that we question with consciousness what language we adopt from overseas to shape our local community. The distinction was embraced with epiphany-like understanding and curious conversation about where sex ends and gender begins. Planting careful seeds of clarity is the essence of such interactions. We have much work to do as a community in our use of language around sexuality and sexual orientation too, but that is outside the present scope. In closure, to explore differences between natal sexes within binary and non-binary variances of gender, as is emergent in autistic populations, the need for relevant understandings has never been more necessary. This is especially potent if we wish to help adolescent natal girls with rapid onset gender dysphoria, no matter the name we give this phenomenon. Research and clinical care have their place, but this phenomenon first takes place within the community, in our families, and in our schools. Local LGBTQI+ networks, along with autistic and neurodiverse communities, most certainly have their place. Yet it is the community sector at large where health workers, youth workers, and community organisations can work together to hold the door open both ways and work collaboratively. Given the prevalence of this trend gaining traction amongst Sunshine Coast youth, I feel it in my heart to work together and let these young people know that we celebrate them whether they persist or desist. We celebrate them whether they are lesbian, bisexual, or straight, and no matter what, they belong always, and it is okay to be who they are, that we support them. I'm Susie, a community health worker on the Sunshine Coast, Australia. Thank you for your time.